will be moderating the session. I would like to invite Dr. D.V. Chiriwala, sir, President IMA KSP, Dr. Siriraju B. sir, Honorary Secretary IMA KSP, Dr. Narayan Murthy C. sir, Chairman, Academic and Medical Education Subcommittee. The moderator for today's session, Dr. H.M. Gurupaksha, sir, uh, Professor, Department Respiratory Medicine, Basveshwara Medical College, Chitradurga, and retired professor and HOD of Mysuru Medical College uh, and Research Institute. And our presenter for today, Dr. Prakriti Kumar RU, an intern in Ramaya Medical College. I would like to request Narayan Murthy sir to welcome our moderator and presenter for the day.
Before that, can we do IMA prayer, Aditi?
Oh, okay, sir. I would like to call upon Vedika to do the IMA prayer.
Yeah.
Okay. May everybody be healthy. May everybody be happy. May everybody be free from pain. May everybody be free from sorrow. May we be healing cure beyond every greed and lure. Thank you.
Thank you, Vedika. Now I would request Swapnil to do the flag salutation.
Yeah. Thank you, Aditi. Sir, I welcome Chinimalar sir. I am a KSP president in his absence who will be joining us soon. Next, I would like to welcome Suri Raju sir, Secretary IMA KSB. And also I welcome moderator of today's session, Dr. Virupakshappa sir, who is a well-known teacher. He was previously head of the department, Mysore Medical College and Research Center. Now at present, he is working with us at Basveshwara Medical College Hospital and Research Center. Sir is a very good teacher, UG and PG teacher, and has a vast experience. He has he has many national and as well as international journals to his credit, sir. And also I welcome the presenter of today's session, Prakriti Kumar RU from MS Ramaya Medical College. So I welcome you, and I welcome all the participants who are joining now. A few are already joined, and also I welcome and thank the technical team of IMAKSB led by Jan. I request Virupakshappa sir to take over the session.
Thank you, sir. Thank you.
Prakriti, you can unmute audio, video, and PPT, and Virupakshappa sir will just say start.
Good evening, everyone. It's an honor to be here and present the case. I shall share my screen. I'm Prakriti Aryakumar, and today I'll be presenting the case. The details are as follows. The patient comes in, whose name is Mr. R. His age is 49 years, is a male resident of Chintamani, and he is a business owner by profession. He comes in with the chief complaints of breathlessness since 6 months, which was exacerbated 4 days back. He had cough since 3 months and fever since 5 days. Patient was apparently normal 6 months back when he noticed breathlessness on climbing one floor of stairs and on uphill. It was insidious in onset and it was relieved on rest. It progressed 2 months back to cause breathlessness while hurrying on the level ground, which also impaired his daily activity, for which he used to regularly visit Chintamani Taluk Hospital to receive nebulization. Symptoms worsened 4 days back to cause breathlessness and walking for about 100 meters. There was no associated wheeze. Coming to the history of presenting illness, there was no history of awakening in, patient was up, and there was no history of awakening in the night or breathlessness on lying down, and there was no diurnal variation. Patient complained of cough for 3 months, which was insidious in onset, and it was associated with sputum. Sputum was scanty in amount, white in color, mucoid in consistency. It was not non-foul smelling and not blood tinged. There was no diurnal variation, and there was no associated postural variation. There's also a history of fever since 5 days, which was low-grade fever on and off, and it was not associated with chills or rigors, and it was relieved on medication. Coming to the negative history, there was no history of chest pain, palpitation, or syncope. There was no history of upper respiratory tract infections. There was no history of night sweats, weight loss, or loss of appetite. There was no history of bilateral lower limb swelling or epigastric pain. There was no history of morning headache, no history of contact with any TB patient, and he has no known allergies. He's not a known case of hypertension, diabetes, tuberculosis, asthma, or heart disease, and there's no history of previous hospitalizations. Family history was not significant. Coming to his personal history, the diet was mixed. His sleep was adequate. Appetite was good. Hydration was adequate. Bowel and bladder was regular. He's a smoker since 30 years, and he used to smoke 1 pack per day, which counts to 30 pack years, and the smoking index is 600. To summarize, a middle-aged male patient who is a chronic smoker with no known comorbidities presented with
Akruti.
worsening breath. Sorry, sir.
Okay, continue.
You should first listen to sir. When he says stop, you should stop and then.
Okay, continue.
Pay attention
Okay,
to
sorry,
sir.
sir. I did not hear that. Sorry.
Continue.
Okay. Middle-aged male patient who is a chronic smoker with no known comorbidities presented with worsening breathlessness from grade 1 to grade 3 and fever since 5 days, cough with expectation since 3 months. And from history, it appears to be of respiratory pathology, probably acute exacerbation of chronic pulmonary disease.
Okay. Now we will come back to the from the preliminary data. The first slide, what you have shown.
Yes, sir.
See, these are called name, age, sex, and address and occupation. These are all called preliminary data. I hope you are very much familiar with all these things. But one thing I would like to highlight on this occasion is regarding the occupation. The occupation here, what you have mentioned is a very broadly you have mentioned business owner. So it is not the occupation, what it doesn't give exact information. So you must ask a particular what type of occupation and what is the correctly he is doing, since how long he is doing, and whether right today is a businessman, business owner. But what is the past, right from about 30 years back, 25 years back? Nowadays, what happens? People will work for some other purpose, and then they'll start their own business. Then they will tell is a business owner. So exactly, I want you to whether you have taken the history properly, business owner or something else he was doing, I don't know. And the thing is, why I am asking is occupation hazards, especially respiratory system. The hazards of the respiratory system by occupation is very, very important. I want you to tell whatever is the things you know, any is occupation which causes the respiratory system.
Yes, sir. There are multiple occupations that cause respiratory system. For example, there can be pneumoconiosis associated with coal. There can be bagasosis for workers who are working in sugarcane industries. And there can be asbestosis for workers who are working in industries that deal with asbestos. Yes, sir. These are the occupation-related respiratory disease.
Yes, you are told very nicely. But one thing is what I would like to tell is the common to uncommon, because daily activity, daily what we see in around our atmosphere, first you have to tell. So common things to uncommon, because so many things you are told, wonderful. Mining industries and other things you have mentioned, it's very important. I agreed with that. But what are the other things in Indian population? There are 80% of the population which are farmers. So there are so many things happens in day-to-day life.
Yes, sir.
Can you tell a few words about the farmers? What sort of occupation that's related to respiratory system they are going to involve?
Sir, there can be bicyanosis with respect to cotton field, and there can be sugarcane workers. There's bagasosis with that. And there can also be associated fungal lung infections when there is when they deal with that, particularly in case of Aspergillus fumigatus.
Okay, I have heard about the farmer's lung, bird fanciers lung, all those things I have heard. And people are working in rubber factory, plastic industry. They're all works in front of. See, you have mentioned about the sugarcane industry and all. Actually, what exact work, even in the sugarcane factory, the office will be there, administrative office. Some people will be sitting in that. If you ask them, where are you working? I am working in the sugarcane factory. But you must understand what exact work they are going to do, because unless they are exposed to the dust or whatever it may be, they will not develop. Office people will not develop the respiratory diseases. Those who are really work in front of that things, they may come across dust atmosphere. There should be dusty atmosphere. So anyway, good. You have told so many occupational hazards related to respiratory system. Let us come to the next to proper history. The chief complaints. You have mentioned about the chief complaints. 3 chief complaints you have mentioned. One is a breathlessness in 6 months. It is exacerbated in 4 days back. Cough since 3 months. Fever since 5 days. See, the gap between these one to another is 6 months, 3 months, and 5 days. See, the patient was in your history you have mentioned. You used to go to the Chintamani hospital to take the nebulization. I don't know whether you are not mentioned every day or once in a week or once in 2 days in a week. You are not mentioned. Anyway, he was taking at home nebulization. But this last point, fever is the made him to get admitted into the hospital. I hope this patient was admitted to the hospital, the presenting case.
Yes, sir.
Okay, so the fever is the one which made him to the admitted to the hospital. So what is the probable? Can you tell fever about the? You have mentioned about the no history of rigors and chills. You are told low grade fever. Fever is the one that make the patient to come to the hospital. Probably it is an infection etiology that may be made a little bit exaggeration of these symptoms. Whatever the breathlessness he had, this may be that made him to come to the hospital. That is the one. See, you have mentioned about the breathlessness. I want you to tell how do you classify the breathlessness depending on the duration?
So breathlessness is mainly classified according to the MMRC grading, sir.
No, I'm not asking grading, causes. Or other way, I would like to ask, can you mention some acute onset of the breathlessness, causes for acute onset of breathlessness?
Okay, sir. So acute onset of breathlessness can be due to acute respiratory distress. It can be due to pneumonia. It can be because of acute exacerbation of chronic lung COPD or acute exacerbation of bronchial asthma. And it can be because of foreign body aspiration, sir.
Any other? Still important? Pneumothorax?
Yes, sir. Spontaneous pneumothorax. It can occur because of the bursting of the bulla, sir.
Pulmonary embolism?
Yes, sir.
Also,
Pulmonary embolism.
these are all respiratory causes. Even in case of the cardiac cause also, so we don't know whether it's a cardiac or pulmonary. Patient is a patient, he will come and present to us his history, but we should know broadly. There are some 7 to 8 causes you have mentioned. In pneumothorax you have mentioned, ARDS you are supposed to mention, pulmonary embolism, acute exacerbation COPD, acute asthma rather than myocardial infarction, foreign body aspiration. All these things are causes the acute onset of breathlessness. Any patient comes to the outpatient or emergency ward between 24 to 48 hours, within that period, that is considered as acute. So you must know each one how to differentiate between the one to another. How to take the pneumothorax history, how to take the COPD history, acute exacerbation. All these things are very important. Here, your patient is having the breathlessness since last 6 months. You are told initially he used to climb, and later used to get the breathlessness on a ring level ground, and later he has to develop even in a routine works also, isn't it? Anyway,
Yes.
yes. Now, regarding the cough since 3 months, can you classify the cough depending upon the duration?
Yes, sir. So there is acute. Sorry. I did not.
Yes, you are right.
Okay. So cough is classified into acute, subacute, and chronic. Acute is less than 3 weeks. Subacute is 3 to 8 weeks, and chronic is more than 8 weeks.
Very good. Very good. So, can you tell me what are the conditions you will get acute cough?
Acute cough, it can be of infectious origin in case of pneumonia, upper respiratory tract infection, and it can be due to foreign body aspiration, and it can be because of development of acute exacerbation of.
Acute cough
It can be because of that. and it can be because of any allergies, and in case of inhalation of dust and smoke.
Okay, subacute cough?
The subacute cough, it can be after a resolution of an infection. It can be post-infectious, post-tussive cough. And it can be because of post-nasal drip. It can be because of a constant aspiration of contents in case of, say, GERD. And it can be because of, yes, sir. So these are the causes.
What about chronic cough?
Chronic cough can be because of chronic lung diseases such as COPD, asthma. It can be because of tuberculosis, infectious causes. It can be because of sarcoidosis. It can be pneumonia, which is not been resolved, and pulmonary effusion. It can be bronchiectasis, which is productive cough,
ILD?
and ILD.
Okay. Can you tell what are the commonly you should understand what are the complications of the cough?
Complications of cough, sir. Complications can be there is excessive, sir.
Rib fracture, sometimes rib fracture can occur.
Okay.
Sometimes incontinence of the bowel, hernias can occur. These are all the complications of the chronic cough. Usually, chronic cough, especially older age, that will produce the hernias, inguinal hernia, and even abdominal hernia, umbilical hernia, whatever it may be. Chronic cough is one of the things which will. You have said associated with the sputum. Can you tell me something about the sputum? Please narrate.
So sputum, it can be based on the appearance. It can be mucus, mucopurulent, purulent, and it can be rusty. It can be frothy sputum. It can be currant red jelly sputum, and it can have black particles. Mucus is usually seen in common infections, common cold. Mucopurulent is seen with pneumonia. Purulent is seen most commonly in bronchitis.
You are mixing with the consistency of the sputum and appearance of the sputum. Consistency of the sputum is mucoid, mucopurulent, and purulent. Whereas by looking at the appearance, you are told rusty sputum. Which condition will get rusty sputum?
The rusty sputum is associated with pneumococcal pneumonia, sir.
Yes. Any other red currant jelly?
Red currant jelly is seen in Klebsiella pneumonia, sir.
Yes. Black sputum.
Aspergillus fumigatus infection.
Blood spotted sputum.
Sir?
Blood spotted sputum.
Blood spotted sputum, it can be because of tuberculosis, sir.
Pulmonary edema. That is a blood mixed sputum in case of the pulmonary tuberculosis.
Okay.
Blood streaked sputum. Blood streaked sputum.
Blood streaked.
Bronchogenic carcinoma.
Okay, sir.
Onchocerciasis. Sometimes, what is onchocerciasis? Which condition will?
Sorry, sir.
Onchocerciasis. The color of the sputum will.
Anchovy sauce. It's seen in case of lung abscess which has been ruptured into the airways.
No, liver abscess rupture into the lung.
Sorry. Yeah, liver abscess.
Yes, isn't it? So
Yes,
in
sir.
your patient, it's a scanty. Is there any postural variation?
There is no postural variation in this
When there
patient.
is a scanty amount, there is no question of the postural variation. Diurnal variation?
There is no diurnal variation.
Diurnal variation, the postural variation, the cough is the sputum will be more.
So postural variation, the sputum will be more in case of bronchiectasis, sir.
Yeah.
And in case of,
which side bronchiectasis? Which suppose if side is lying down?
sir, when he's lying down on the side of the affected lung, there can be
Suppose if the right side had bronchiectasis, lower lobe bronchiectasis, pakka right side. When the sputum will be more, which side if it goes?
So when he lies down to the left side, there'll be movement of the sputum, sir.
Yes. Yes. Continue.
Okay. So from which slide should I continue, sir?
Yeah.
Okay. Coming to general physical examination, patient, a middle-aged male, moderate was.
Till Past history I have told, no? Personal history of past history.
Past history, there he has no known comorbidities and
And
no
your history of presenting illness, negative history I have told something. No history of chest pain, some palpitation, something.
Yes, sir. There is no history of chest pain or palpitation, sir. This is
Why
mainly
did you
to,
ask, why did you ask this question?
so this is to rule out cardiac causes for breathlessness, sir.
Yeah, that's correct. So cardiac, if the breathlessness is cardiac origin, you have to ask chest pain, palpitation, even syncope also. So you asked about the night sweats, weight loss, and loss of appetite. Why did you ask?
Sir, weight loss and loss of appetite can be associated with tuberculosis. And night sweats, because of the fever history, night sweats are one associated with tuberculosis. Second, it can also be because of Hodgkin's lymphoma, the B signs, sir.
Okay, now what about the you are written no history of bilateral lower limb? See, lower limb, any swelling in the limb, that's unilateral and bilateral. I am a chest physician. Unilateral limb is also very important. Why? Can you tell me why unilateral limb swelling is also important? Which condition unilateral limb important to the respiratory physician or any general medicine? What is the important catastrophic condition will occur if the unilateral limb? DVT. Have you heard about DVT?
Yes, sir. Yes,
Deep
sir.
vein thrombosis. What will happen from that?
If there's dislodgement of that, it can cause pulmonary embolism, sir.
Pulmonary embolism. It is a very emergency condition. Pulmonary embolism is a life-threatening condition. So whether it's a unilateral or bilateral. Okay, you are written bilateral. In what idea you asked about the bilateral limb swelling?
Sir, I was looking for the sign of right heart failure wherein there is
Yes.
edema.
Yes, next. No history of morning headache. Why?
So morning headache here was mainly to look at the history of sinusitis and that, sir.
No, any respiratory physician. What? Of course, that's also important. Morning, even sinusitis is also important for respiratory physician. Here, other condition is like especially type 2 respiratory failure. Type 2 respiratory carbon dioxide narcosis or carbon dioxide retention. At that time, there will be morning headache will be there. That's one of the important condition. Especially in this case, COPD patients goes to the respiratory failure. They develop type 2. In any case, any cause for type 2 respiratory failure, they may develop the morning headache. One of the symptom is morning headache. Yes.
Okay, sir.
Continue. Past
Yes,
history.
and he has no history of contact with tuberculosis patient, and he
Yeah.
has no known allergies, sir.
Okay. Next.
And past history, he personal history. Okay, sir. The significant history we can get from personal history is he's a smoker since 30 years.
Yeah.
1 pack per day.
Good. Smoking. When do you call a person is a chronic smoker? When do you call a person is a chronic smoker?
When he's been smoking.
Okay.
For
You said 1 pack. Totally, what is your pack years?
30 pack years, sir.
What is smoking index?
Smoking index is 600, sir.
So you will consider him as a pakka smoker. What are the smoker induce problem into human being? For not only the respiratory, anything. Right from head to toe. What is the hazards of smoking or problem starts with the smoking? From head to toe.
Okay. Problems of smoking, it can be, first it can cause or increase the risk of several cancers such as lung cancer, colorectal cancer, and it can cause cardiovascular disease wherein heart disease, and it can contribute to the pathogenesis of stroke. In respiratory problems, we have COPD and asthma, and it can also cause, it can contribute to the pathogenesis of immunological conditions.
Bronchogenic carcinoma, one of the commonest, isn't it? Smoking
Yes,
induced bronchogenic carcinoma. Is there any history of alcoholic?
There is no history of alcohol consumption in this patient.
So other important causes of smoking, hazards of smoking is human peptic ulcer. One of the important in surgical condition is Burgess disease. As you have seen, TAO, thromboangiitis obliterans.
Obliterans,
That's
yes.
one of the important. See, we want to prevent not only the respiratory thing, we can prevent so many other diseases. If you counsel and if you properly stop smoking, you can prevent not only your respiratory, all the problem from head to toe you can prevent. So, is there any history of alcoholic? It's not mentioned here.
He denies alcohol consumption.
How the respiratory smoking causes a respiratory problem?
Sir, smoking, because of the nicotine, the effect of nicotine, it goes and binds to the nicotine receptor, which is alpha 4 beta 2 receptor. That one can cause vasoconstriction. Second, it can also go and inhibit the action of alpha 1 antitrypsin, which is there essentially there to for the degradation of elastase. And because of this, there is no degradation of elastase, and as a result, there's destruction of the lung parenchyma, sir.
Any other mechanism? Have you heard about mucociliary blanket?
Sir?
Mucociliary escalator. Mucociliary escalator.
Oh, yes, sir.
It will destroy the immune system by destroying the mucociliary escalator. It increases the goblet cells, increases the hypertrophies of the mucous secreting cells, all those things. Have you heard about the Reed index?
Reed's index, sir.
Reed index.
Sir,
Okay.
it's used in context of chronic bronchitis for for assessing the extent of the mucus gland proliferation in the bronchial wall, sir.
Okay. Have you not mentioned about the alcoholic? Is there any history of alcoholic?
He denies alcohol intake, sir.
Okay. Let us discuss how the alcohol will produce the respiratory problem.
Sir, alcohol, first, it causes central respiratory depression, which causes symptoms like bradypnea, and there can be instances of aspiration, which can cause aspiratory pneumonitis.
Yes. See, alcoholic patient will be they will not be much conscious. So they will be having the chances of vomiting on and off. They won't take food properly. There will be chances of vomiting is there. They can go for aspiration. Then it will cause repeated aspiration causes the declines the immunity of the lung. Again, there will be so many problems will occur. Right?
Yes, sir.
Okay. See, you have summarized it in this way. Don't jump directly into the COPD because this way is taken. Some of the patient will not give the proper history, or we have not taken the proper history. See, this patient has smoked for a period of 30 years. He has given the history only for the last 6 months or 6 months. So definitely small things they won't take into the consideration. The exact problem when they start, then from that day they will tell. Some people will just neglect. So all those things. So either history has to be a little bit, you have to be very careful in taking the history, digging out of the history. A person who smokes for a period of 30 years, it cannot be just 6 months also. Anyway, there are some conditions straight away. We cannot come to some conclusion. So there are some differential diagnoses we can think of regarding the breathlessness and cough. Here the predominant symptom is a breathlessness, that too since long 6 months, and cough is only 3 months only. Not to with the extent of a small, more sputum is not there. So we have to think about the differential diagnosis. Like, can you think about the interstitial lung disease in this condition?
Yes, sir. There is a possibility of interstitial lung disease as well.
Yeah, because there is a progressive increase in your pattern of the breathlessness. Now let us come to the afterwards. Let us come to the general physiology. If it's possible, we will rule out one by one. So there are so many conditions, but in this history, I cannot think about suddenly pneumonia. I cannot think about the bronchiectasis. I can't take the stage of malignancy. It cannot be like asthma, because you have to think carefully. You have to little bit more carefully. You have to take history, and again next you go for the examination.
Okay, sir. Coming to the general physical examination, patient, a middle-aged male who is moderately built and poorly nourished, is conscious, cooperative, and is alert, is well-oriented to time, place, and person. His BMI is 20.3 kgs per meter square. Vitals, pulse is 73 beats per minute. It's normal rate, rhythm, volume, and there's no radial or radiofemoral delay. All the peripheral pulses are felt, and there is no vessel wall thickening. Respiratory rate is 20 cycles per minute, and it's thoracoabdominal in type. Blood pressure is 124 by 82 millimeters of mercury, measured in right upper arm. Temperature, he is afebrile and the measured temperature is 98.2 Fahrenheit. There was no signs of pallor, icterus, clubbing, cyanosis, edema, or lymphadenopathy, and spine appears to be normal.
So one thing you have left in the general physical examination, that is JVP. JVP, is it not important for a respiratory case?
Yes, sir. I mentioned it in the cardiovascular system, CVS examination,
I
sir.
think better to mention in general physical examination JVP. From head to toe, while doing head to toe examination, JVP
Okay, sir.
should come in a then. Let us come from the pulse you have mentioned. Of course, if presently the patient is not in distress, probably my fever might have come down. He has maybe given some treatment. Have you taken what treatment he has given and all properly?
Sir, at the time of examination, the patient's symptoms were had subsided,
Yeah,
sir.
yeah. So you might have taken some treatment that made him to fever has come down probably and all. That's why his pulse rate is normal, 73 per minute. And another thing is, you ask all peripheral pulses felt. Can you name some peripheral pulses from head to toe?
Yes, sir. From head to toe, it's in the upper arm, it's brachial artery, axillary artery, radial
Before
artery,
that,
and
still more. Instead of brachial artery, go for above.
yes, sir. In above there is auriculotemporal artery
Temporal
and
artery, temporal artery, preauricular, carotid artery, axillary artery. Then continue.
axillary artery, brachial artery, radial artery, ulnar artery. And coming to the lower portion, there is femoral artery, popliteal artery, and anterior tibial and posterior tibial artery, dorsalis pedis artery. Sir.
Dorsalis pedis. Okay. What you have mentioned 20 cycles per minute. You have mentioned thoraco-abdominal. Who is a male patient? Usually, male patient, what is the type of these things you will get?
Sir, in male patient, it's predominantly abdominothoracic. Sir.
Yeah, but it's mentioned as a thorac. Correct it. Okay.
Mm.
So you have mentioned blood pressure. So in what way the blood pressure is related to the respiratory system?
Sir, blood pressure there can be variation in the blood pressure with respect to there can be high bound pulsation.
Oh, okay. You have taken me to back again. Pulse you have mentioned, no? So, well, in what way it is important for a respiratory case? Again, sorry, you have taken back once again.
Yes, sir. So the rate, it can, since the patient has fever, there can be increase in the rate. And rhythm, there can be irregular rhythm, wherein in COPD patients, we see MAT, which is multifocal atrial tachycardia. And volume, there can be high bounding pulse because of hypoxia. And yes, sir.
Carbon dioxide narcosis.
Carbon.
Bounding pulse, that's one of the important type 2 respiratory failure. The pulse is bounding pulse. Now let's come back to our this thing, blood pressure. In what way it's important for respiratory case?
Yes, sir.
There are two conditions, important condition. What is the terminology called? Pulsus paradoxus.
Yes, sir. Pulsus paradoxus in
What are the
COPD case.
condition? What do you mean by pulsus paradoxus?
So there is decrease of systolic blood pressure by more than 10 millimeters of mercury during inspiration. Normally it is less than 10, but in this case it's more than 10. It's seen in case of COPD, in constrictive pericarditis, in cor pulmonale, which is a complication of COPD, sir.
No, not just COPD. It is it's acute exacerbation of COPD. That you have to mention. Acute exacerbation. And it's acute asthma. Acute asthma is another condition where we, of course, all these things we may not practice daily, routinely, but still, whenever the discussion comes, all these things we will discuss. And but the clubbing you have mentioned, no clubbing, isn't it?
Yes, sir. There is no clubbing.
Can you mention important causes for clubbing?
Sir, the respiratory causes for clubbing can be malignancies in case of lung cancer, mesothelioma, and they can be, in fact, pyogenic causes in case of lung abscess. It can also be seen in bronchiectasis, and in case of uh, and then I can think of, and in case of interstitial lung disease, and it can also be seen in cystic fibrosis, sir. And in case of heart diseases, sir,
empyema.
empyema, sir. Yeah. Sir.
Which condition very fast occurrence of the clubbing? Very fast. You are told 5 conditions. Agreed. Among 5, which condition may occur very fast?
The lung abscess has
No, empyema. It's very fast. Within 12 days,
okay.
14 days, it will occur. About lymphadenopathy. You have searched for lymphadenopathy? No lymphadenopathy. Why you want to say search for looking for the lymphadenopathy respiratory system? Which
So,
group of lymphadenopathy?
It's mainly cervical supraclavicular lymphadenopathy, sir, because the lungs.
What are the possibilities?
It's mainly for looking for the malignant causes of lymphadenopathy in this case, sir.
How malignancy straight away go to the lymph node? From where?
It goes first to the hilar lymph nodes, and from there it drains into
You are telling, you mean to say metastasis, isn't it? From which are all the organs, supraclavicular lymphadenopathy can occur. Different organs in the body.
Okay, supraclavicular. Sir?
Lung, from the lung, different organs, lung, GIT, prostate. From where malignancy, it will be metastasis to secondaries, isn't it? Some metastasis to lymph nodes.
Yes, sir.
And one more thing, again, you have completed edema. Where exactly you would like to see for edema, pedal edema?
The pedal edema is seen at near the ankle, sir. It's by pressing against the.
Where exactly?
Above the medial malleolus, sir.
Half an inch above the medial malleolus, isn't it? You have
Yes,
done
sir.
icterus. In what way in respiratory cases icterus is important?
Sir, in case of alpha-1 antitrypsin deficiency, there is associated liver cirrhosis which can lead to presentation of icterus, sir.
Any other common conditions in day-to-day involved? We are treating tuberculosis, pulmonary tuberculosis, whatever
yes, sir.
tuberculosis.
Rifampicin, isoniazid, and pyrazinamide.
Jaundice, isn't it?
Yes, sir. Yes, sir.
Spine. You are examined for spine. You are written normal. Why you want to examine the spine?
So there is, in case of COPD, there can be kyphosis of thoracic vertebrae, sir.
Any other condition? Have you heard about the TB spine?
Yes, sir. Pot spine, sir.
Yeah, hot spine, tuberculous spine, isn't it?
Yes, sir.
So, in this, let us come to the later regarding the full discussion about the diagnosis spinal. First, please, don't jump into the chronic obstructive disease and all, because it is not very difficult to put into the one single diagnosis. The history is not that way. So, you have done general physical examination, now systemic examination.
Yes. Systemic examination for the respiratory system, the upper respiratory tract. The nasal cavity appears normal. There were dental caries present in the oral cavity, and pharynx appears normal.
But have you not examined the sinuses? It's also part and parcel of upper respiratory tract.
Yes, sir.
Isn't it? In what way sinuses examination is important?
So since he gives a history of fever, there can be sinusitis associated with this. And there's another condition which can be associated with sinusitis, which is the cartilaginous syndrome. That has lung presentation, sir.
Which condition, cartilaginous syndrome? Which condition?
It causes bronchiectasis, sir.
Yeah, in bronchiectasis comes under the bronchiectasis. Cartilaginous. What are the other syndromes in bronchiectasis?
So there is.
Okay, too much for you. Anyway, so how does the sinuses problem related to respiratory system?
So there can be sinusitis which causes the infection, which can cause the exacerbation of this condition, sir.
Okay, read next. Oral cavity I mentioned. In what way respiratory system examination, you have to see oral cavity thoroughly. What is your examination finding oral cavity? I have to go back there.
Sir, yes, sir.
Have you examined oral cavity in general physical examination?
Not
No,
in
it is
general physical examination,
not
sir.
mentioned anything.
No, sir.
So oral cavity examination is very important for respiratory physician, respiratory case. How oral cavity is important? Why you want to do that?
Sir, in case there can be presence of halitosis, wherein in cases of bronchiectasis because of the pus, there can be, in case the patient is on ICS, which is inhalational corticosteroids, there can be presence of oral thrush. And
See, one thing, please understand, most of all the patients need not have corticosteroid. See, all corticosteroid immediately produce oral thrush unless it's a long term and doses more and all. So commonly, you have to search for oral thrush is for immunocompromised state. What is that compromise? HIV, isn't it?
HIV.
So that is, we have to search for that. And what is the other oral pathology you would like to see? Oral problem? In what way it is related to the respiratory system? See, it's a bad oral agent, especially pyorrhea. There are so many oral cavities bad. The pus is producing gums and pyorrhea alveolaris and gingivitis. They're all produces microaspiration. Microaspiration that colonizes in the respiratory tract. The patient will develop the pneumonia, lung abscess, bronchiectasis, and all those things. So very important. It's a oral cavity examination. Yes. And at the same time, you can see the any congenital anomalies is also there. If you have to say soft palate, hard palate, there may be something else, there anomalies, and there may be post-nasal drip. You have to examine. You have to examine thoroughly with the proper tongue depressor and light. Just oral cavities are not sufficient. So please remember, it's directly related to the pneumonia, lung abscess, and bronchiectasis. Yes.
Okay, and pharynx appears normal, sir. Coming to the lower respiratory tract, on inspection, the chest is barrel-shaped and is and bilaterally symmetrical. Trachea appears to be central. Apex beat cannot be visualized, and there was no use of accessory muscles of respiration. There was no dilated veins, scars, or sinuses visible on chest wall, and spine appears central, sir.
You have not mentioned here an inspection, movement of the chest. See, these things should come in a simultaneous shape of the chest, symmetry of the chest, movement of the chest. Shape of the chest, symmetry of the chest, movement of the chest should come in a single line, and you can explain one by one. Shape, what is the shape you have mentioned? Barrel-shaped chest.
Yes.
Isn't it? Can you name some other chest deformity in the respiratory system?
Sir, there is.
What is the normal chest?
So normal chest is it has an anterior-posterior.
What do you call that? What is the shape of the chest? Elliptical.
Elliptical, sir.
Here is a barrel-shaped chest. Elliptical has become barrel-shaped chest, isn't it? Any other chest deformity in case of the respiratory system?
So there can be pectus carinatum, pectus excavatum. There can be rachitic chest and scorbutic chest.
Okay. So you have mentioned barrel-shaped chest. What are the points to say it's a barrel-shaped chest?
So the anterior-posterior diameter to transfer diameter, the ratio should be 1:1, sir.
You complete your examination. Where respiratory you first finish. Let us discuss afterwards.
Okay, sir. And coming to the palpation, the inspected findings are confirmed. Trachea is central in position. Apex beat was palpable in the fifth intercostal space at 1.5 centimeters medial to the midclavicular line. There was no local rise of temperature, and the movements of chest was bilaterally symmetrical. Tactile vocal femtus showed a diminished picture in all the areas and bilaterally. Coming to the measurements, transverse diameter is 27.5 centimeters, anterior-posterior diameter is 25 centimeters. Chest circumference on expiration was 82 centimeters and on inspiration was 83 centimeters. Right hemithorax was 41 centimeter on expiration and 41.5 centimeter on inspiration. Left hemithorax was 41 centimeter on expiration and 41.5 centimeters on inspiration. For the chest expansion, the right hemithorax showed an expansion of by 0.5 centimeters and left hemithorax by 0.5 centimeters, and total chest expansion was 1 centimeter.
Next.
The percussion showed hyperresonant note on bilaterally on all areas of lung fields, and cardiac dullness was obliterated, and liver dullness was noted at 6th intercostal space in the right mid-clavicular line.
Okay, next.
Auscultation showed diminished vesicular breath sounds bilaterally in all the areas. Vocal
Next.
resonance was bilaterally equal in all the areas.
Next.
Coming to the other systemic examination, per abdomen was soft, non-tender, with no organomegaly. Bowel sounds were heard. Central nervous system showed that higher mental functions are normal. There was no flapping, tremors, or altered sensorium. There was no focal neurological deficit. Cardiovascular system showed that S1, S2 was heard. There was no murmurs and no added sounds. JVP was not elevated.
Okay, let us, before going to summary, let us come to the your inspection, palpation, and all. Inspection. What is your inspection findings?
So the chest was
Inspection
barrel
findings
shaped.
are confirmed by the thing. See, you have written trachea is in central position. Certain books are telling certain examination students also say slightly deviated to the right side. That's a common thing I've seen the majority of the times. Slightly deviated. Yes, of course, normally also maybe slightly deviated to the right. What is the cause for that?
So the right bronchi is is shorter and
No, that's not the
has-
thing. It's the arch of Ida comes that. Read that. Tracheal.
Okay.
See, one of the
Okay.
important thing your contradictory statement here affects me with the palpably left fifth intercostal space you have written. But on inspection, you have said not visible. And the chest picture you have shown barrel shaped chest. It is not at all possible from even experienced person also in barrel shaped chest to elicit the what is the apex beat. It's very difficult. That you have to be very careful. You have written no inspection, not visible. Palpation, you have mentioned fifth intercostal space, 1.5 centimeter to mid-clavicle. It is not so like that. It's not possible. Okay. What are the other conditions where you are not able to find the apical impulse?
Sir, it can be physiological, it can be pathological, and physiological apex beat can be superimposed by a rib. Pathologically, it can be because of hyperinflation of lungs. It can be because of massive pleural effusion. It can be because of pneumothorax. And yes, sir.
Certain times, very rare condition like a dextrocardia, there also you are not able to palpate the apical impulse, isn't it? If it is behind the rib, if it is obesity, there also you are not able to palpate the apical impulse. See, you have written tactile vocal perimeters. You have written diminished. You have shown it's a diminished. Instead of that, while the word diminished means we have to see some normal finding should be there. So unless you compare to the something, you cannot say some. You should say equal on both the sides. So probably in our experience, it's maybe different because you have to keep on examining the so many patients, no? So their tactile local perimeter something like that. But here pathological things are equal on the both sides. It appears to be diminished. That is better than that diminished, right?
Okay, sir. Yes, sir.
Equal and see you are keeping your background examination findings so that you can tell that. So you have measurement is okay. Measurement normally 1:1 should be there. It is going to the barrel shape. Still 25 anterior posterior, 27.575 transfer. It is on the way to the barrel shape test. So can you tell me what are the things to say barrel shape test? Who do you say it's a barrel shape? You have measurement done. Tell me how do you one is anterior posterior diameters almost equal. Any other findings to say barrel shape?
And it appears to be more rounded, more circular than normal. Normally, where there is flattening, there's more circular here. And then there is increased, the subcostal angle, which is normally 90 degrees, is increased in this case. And yeah,
What about the intercostal space? That's
the
wide
intercostal space will increase, sir.
are placed horizontally, isn't it? Whole
Yes, sir.
thoracic will be okay, fullness, isn't it? Because
Yes,
of
sir.
lung volume.
Yes, sir.
And percussion, you are written hyperresonant, again the same problem. See, we need something to compare. Otherwise, it's very difficult. So, if the unilateral pathology, definitely we can compare one side to the normal to the abnormal, always. But here, the bilateral, it's again equal on the side. It looks like a hyperresonant note. Can you tell me what are the different percussion notes?
So there is
What is
tympanic, there
impaired?
is
What is impaired?
impaired, sir.
Impaired note. When do you call impaired? Where do you get impaired?
So there's physiological and there is pathological. Physiologically, there is impaired note in case of when we are percussing for the cardiac dullness, and
No, impaired note. The altered resonance, altered normal resonance is called impaired note. Number one. Number
Okay,
two is a dull note. Number three is a
Hmm.
stomatal note. Next is a tympanic note, or hyperresonant note. Next is a
Yes.
tympanic. Where do you get tympanic note?
So tympanic note is a drum-like note, which is normally seen in the trob space, sir.
Why they will get tympanic note?
So trob space is
No.
essentially reflecting the fundus of the stomach, which
Yes.
is filled with air, sir.
All those structures you will get a tympanic note, isn't it?
Yes, sir. Yes, sir.
So, what else you would like to percuss in the respiratory system examination? Special percussions are there. I don't want all, only one will tell. There is a condition called chronic systematic urine.
Yes, sir. In chronic isthmus,
And tidal percussion, where to get upper part of the liver dullness?
Sir?
Normally, upper part of the liver dullness.
Yes. In the right midclavicular line, we usually find it in the fifth intercostal space.
In liver condition, it has gone down.
Yes, sir.
Because of hyperinflation, isn't it?
Yes, sir.
Auscultation. Also, you are written diminished. Again, equal on the both sides, but appears to be diminished. Better the word is there. So, vocal resonance, again, here you are written bilateral equal. Of course, bilateral equal, you are written. Now, other system examination, parabdomen, what else your findings?
Parabdomen, there was no significant.
When the liver is pushed down, normally, usually we can palpate small liver border also. I am not telling a enlarged liver. Because of your pushing the liver from the lungs to the lower part, you may get sometimes, if you examine properly. And central nervous system, already in general physical examination you have mentioned. And cardiovascular system. So this patient, what is carpulmonal? What is carpulmonal?
Cor pulmonale is a condition that results due to right ventricular failure, sir, because of when there is.
Two words are there. Cor pulmonal. Cor means cardiac. Pulmonal. Cardiac disease secondary to lung disease. That is called cor pulmonal, isn't it?
Yes,
cardiac disease secondary to lung disease. Cor pulmonal. So, have you heard about acute cor pulmonal? Usually, general cor pulmonal is very, very chronic for 10 years, 15 years. Have you heard about acute cor pulmonal?
Sir, it is the sudden onset condition where there is when the right ventricle enlarges and weaknesses due to sudden increase.
Read. So, what are the things about what are the changes will occur in the carpulmonal patient went to the what are the picture? Chronic patient goes to the what are the problem pathology will develop? Chronic respiratory disease, whether it's a COPD, whether it's a COPD patient, lung destruction, lung. So many things are there. Lung pathology, so many. Bronchitis is there, interstitial, and so many conditions are there. Like they will end up in what tension? What tension?
Pulmonary hypertension.
Pulmonary hypertension. Pulmonary hypertension. What is the normal pulmonary artery pressure? Is it equal to systemic pressure, or is more than the systemic pressure, or less than the systemic pressure?
Sir, pulmonary artery pressure is less than sorry,
Of course, you have to read that, isn't it?
yeah,
So
it's around 25
very good,
millimeters
very
of
good. At
mercury,
rest,
sir.
it should be around 25 symbolic. Okay. Then why it is less? The pulmonary pressure is less compared to systemic pressure. Why? Systemic
Sir,
pressure 120 by 80, here 25 by 10 or something like that. Why? It is so grossly different.
so firstly, it is because of the left ventricular pressure transmission, sir. Second, since it's for the pulmonary circulation, it has to be less to ensure adequate exchange of carbon
No,
dioxide
no,
and
no.
oxygen.
It's a wide distribution. Resistance
Okay.
is less, isn't it?
Yes,
Okay.
sir.
Now, can you tell me what are the signs of right heart failure? What is the signs of symptoms of pulmonary hypertension? How does the pulmonary hypertension, if they develop the pulmonary hypertension, what are the probable symptoms maybe?
Sir, it shows symptoms of right-sided heart failure symptoms, sir,
Yeah.
which can be which can lead to three signs, which is raised JVP. There is
No, no, I'm not asking right heart failure. First, it will go for pulmonary hypertension, then right heart failure.
okay, so
Okay,
symptoms
signs of
can
right heart
be
failure. Read about that. Right heart failure, you tell.
okay. Symptoms of the right heart failure, sir.
Hmm.
So right heart failure can lead to three symptoms,
Yes,
which is
tell.
sorry, sir.
Increase JVP.
Yes, sir. Increased JVP. There is swelling, which edema, and which can lead to that hepatojugular reflex. And
Enlarged tender already failure is already there. Instead of reflexes, is still so JVP is increased. What are the waves in JVP?
so JVP waves. There are first there is
Waves,
A
waves,
wave. Sir.
positive waves, negative waves.
Yes, sir. First, there is A wave, which is atrial contraction. The another positive wave is the C wave, which is ventricular contraction, and after that, it's V wave, which is for the right atrial filling. And for the negative waves, there is X wave, which is for the right atrial relaxation, and Y wave, which is for the right atrial
Okay,
emptying,
okay,
sir.
okay, okay. Now let us come with that. There's no short of time. We'll come to see. We'll go back to the any other. First, we'll discuss the case. So again, you cannot put it into straight away any proper disease. So still, is it? It cannot be bronchial asthma because there is no picture of what is the difference between bronchial asthma and your distance COPD.
So bronchial asthma is predominantly it's only a airway disease, sir, whereas COPD can be it has multiple levels. Where in case of chronic bronchitis, it is a large airway disease with parenchymal involvement, whereas an emphysema is a small airway
Right,
disease
right,
without
right.
parenchyma.
See, bronchial asthma age. First of all, age is already crossed some 46 or something like that. The asthma is usually chronic bronchitis, emphysema. It's all after the age of 40, 55.
Yes,
That
sir.
will develop as a chronic smoker. They may develop a little bit early. Whereas asthma is not like that. It starts from the childhood. You should take childhood
Yes,
history of asthma also. Because
yes, sir.
in the childhood, sometimes the asthma will be there by 10 years, 12 years, it will be disappear. Again, will recur after the age of 40, 50 also. You have to be very careful. You have not taken that history. And tuberculosis is very unlikely. Tuberculosis patient will not be there for 6 months to 8 months of breathlessness. When do you get
Correct.
the breathlessness in case of tuberculosis? Means if it is a parenchymal lesion, if it is purely parenchymal lesion, first is the cough, fever, other things will develop. Later, if the patient will not take the treatment for months and months together, there are some patients are there. Even after 6 months, they will never come to the hospital because of the so many reasons. So many whether socioeconomic problem and nobody is going to take care of that. The people have come to us with almost extensive lesions of that, but not at a period of 8 months. 8 months is too long to wait for the tuberculosis. Only if it is one case is that this means that is against the tuberculosis. So bronchial asthma is also it's not it, but only on the basis of your examination findings. So examination findings, he has said the barrel-shaped chest. The barrel-shaped chest will not occur immediately. It will take years and years and all. Probably the history might have missed by the patient or they have not given the proper history. That is the things based upon the history of smoking. It's very important, smoking and barrel-shaped chest and other signs of auscultation, percussion. We may take as one of your diagnosis. What is the diagnosis you have mentioned? Final diagnosis, acute exasperatation, obstructive lung disease, predominantly emphysema, isn't it? So,
Yes.
what is the difference between emphysema and chronic bronchitis? What is the mechanism of emphysema? Mechanism?
Sir, emphysema. Sorry, sir.
How the mechanism of emphysema?
The emphysema is it can be. Are you asking the etiology, sir, or the mechanism of?
No, mechanism.
Okay, sir. So due to different etiologies, it can cause inflammation of the lung parenchyma, essentially the alveoli, which causes release of various enzymes, including the elastase and
elastase was this thing. There is inflammatory pathology. The other things is predominant symptoms in case of emphysema. What is the predominant symptom in emphysema?
Sir, emphysema patients are also called as pink puffers because they have the predominant symptom of hyperventilation.
Breathlessness. Here the chronic bronchitis predominant symptom is cough.
Yes.
Next we will come to the sputum. Sputum is very less chances. Where here there will be more sputum. Cyanosis in emphysema chances are less, whereas chronic bronchitis early cyanosis will be there, isn't it?
Yes.
So all things, whatever may be your thyrometry test, your what is that pulmonary hypertension, whether it's heart failure, all are late, very late in case of emphysema, whereas occurs in the early in case of the chronic bronchitis. So can you tell me the definition of chronic bronchitis?
Yes, sir. The clinical definition for chronic bronchitis is the cough with sputum for more than 3 months or cough for more than 2 years, sir.
Yeah, your patient definitely it is not going to fit for chronic bronchitis definition because his symptoms is only 6 months. 2 years has to complete to say if you want to tell about the chronic bronchitis, 2 years has to complete. Isn't it? And in your case, I would like to ask you one question. You are not mentioned about the seasonal variation. Is it right to take seasonal variation in your case?
So seasonal variation can point towards bronchial asthma, sir, because in the winter seasons it can be.
In your case, not necessary because he has not completed 1 year complete. Again, just 6 months all season will not come in 6 months. So 1 year has to complete. Then only you can take seasonal. Otherwise, you should not take. Yes, you have gone to the next investigations.
Yes, sir.
You have done some investigations, no?
So investigations to be done include complete blood count, sputum for culture and sensitivity, and CBNAT in case since we are suspecting tuberculosis as well. Chest X-ray, PA and lateral view, and spirometry, which is the investigation of choice in case of COPD, and HRCT, sir.
Any other investigation you would like to do? Routinely, these are all routine cases. Routine since the patient is having 6 months of breathlessness, 6 to 8 months, 6 months of breathlessness, everything, whatever it might be. Is a smoker. You want to do any other, at least ECG, echo, all those things you would like to do?
Yes, sir. ECG to see for the signs of for pulmonale and echocardiography to see for the heart wall, sir. And we can also do DLCO in this case, sir.
Yes, DLCO, you are supposed to do it.
Yes, sir.
Yes. Sputum culture and sensitivity you have written, CBNAT you have written. What is CBNAT?
So CBNAT is to look at the
What do you expand that?
So CBNAT is cartridge-based nucleic acid amplification test, sir.
Yes, it's a molecular diagnostic CBNAT, cartridge-based nucleic acid amplification test. How much time it will take to get the report?
Sir, it takes the turnover time is 90 minutes, sir.
What it gives a report?
Sir, report first it gives it talks about the presence or absence of Mycobacterium tuberculosis, and if it is present, it gives a report if it's resistant for rifampicin or not.
Yes, rifampicin. Yes. So you have mentioned it was a chest X-ray. Can you show me the chest X-ray?
Sir, the chest X-ray was not done for this patient during the.
Okay, no problem. Suppose if you are telling that emphysema patient, what will be the X-ray picture in emphysema?
So first is we see hyperinflation of the lungs, and there can be flattening of the diaphragm, and the pulmonary vasculature is decreased, and in case of heart, there can be the tubular heart can be seen, sir, because of the hyperinflation. There's a compression of the heart forming, leading to a tubular heart. So,
How do you depress the diaphragm? Any heart size heart, this thing, what is it, tubular heart. In hyperinflation, the heart will go in the form of little bit tubular heart. Have you heard about
yes,
tubular
sir.
heart?
Yes, sir.
What made
Tubular
you,
heart is seen
what
in this
made
case,
you
sir.
tell diaphragm is flat?
Sir?
Diaphragm is a flat, you said no.
Yes, sir.
What made you to tell diaphragm it is a flat?
Sir, diaphragm will be pushed downwards by the
No, X-ray picture you are telling flat diaphragm. On what basis you are telling diaphragm is flat?
so the
See, you have to do a line from the costophrenic angle to the cardiophrenic angle, from the
yes,
midclavicular
sir.
line to the line, that has to come and sit in the midpoint of the diaphragm. The normal, you join that line and the midpoint of the diaphragm, it should be more than 1.5 centimeter. If it is less than 1.5 centimeter, it is called flat diaphragm.
Flat diaphragm.
Got the point? So, this, what about the HRCT? Is there any HRCT?
So HRCT is yet to be done, sir, in this patient.
Okay,
But we
okay.
can look for
Important thing you have done, spirometry, isn't it? What
yes,
is the
sir.
spirometry findings?
So in spirometry findings, the FEV1 by FEV ratio will be less than 0.7, sir, in case of
0.7.
obstructive. Yes, sir.
As per the gold guidelines, it should be less than
0.7, sir.
0.7. So you have given lastly treatment. How do you treat this condition?
So there is gold guidelines for the treatment.
Other than the lung function spirometry, other than anything you would like to do, lung functions related special test you would like to do, because you are told hyperinflated lung. Any other things? Higher things. To find out the total lung volume, residual volume, functional
So we can
capacity.
do body plethysmography to find out the residual volume, sir.
Total lung capacity. So,
yes,
you have
body
the
plethysmography.
treatment aspect, no? Can you tell something about the treatment you have written? 4 points.
First treatment is smoking cessation, sir. We can give them alternatives for the smoking, like nicotine gums, nicotine patches. We can also give them treatment for with varenicline and bupropion, and treat according to the category of the patient. So we'll
Smoking cessation, it is not so easy as you tell. Smoking cessation means it will require special sessions, and there will be some specialized people who should be there. They have to, what we call for them, counselors. So
yes,
it will be time spending is very important. It's not like just telling as a smoking cessation. It has got its own method of telling and demonstrating and all those things. So it's very important. I already mentioned smoking cessation. You will not prevent only COPD, asthma, and other COPD and bronchitis. It will prevent from head to toe so many things. And next is treat according to the category of the patient. Suppose if you consider this patient as a COPD, for example, which category it comes?
Sir, since we are not sure about the exact.
The COPD for at least. How do you categorize?
So we categorize based on category 1, 2, 3, and 4. So
no. What is the gold classification?
Oh yes, sir. So sir.
As per the gold guidelines.
So as per the gold guidelines, we treat according to the symptoms and the risk, which is the exacerbations. So if the patient is low risk and has low symptoms for which is less than 1 hospitalization per year, and symptoms are the MMRC grade 0 to 1.
Written some antibiotics for the fever. For fever only you give antibiotics. You don't want to give antibiotics for cough.
Sir,
You
in
have to
case of chronic lung disease in COPD, we can give azithromycin, sir, because it has anti-inflammatory action and also prevents the infection, sir.
you are written oxygen therapy, isn't it?
Yes, sir.
So the patient has come with the history of exacerbation, or after the fever only has come to the hospital. He has come to the hospital. You have to treat whatever the exacerbated condition like breathlessness, fever, all those. You have to treat first that, then you have to give treatment. Have you heard about LTOT? What is LTOT?
Uh,
Long-term oxygen therapy. Long-term oxygen therapy. Have you heard?
yes, sir. Long-term oxygen therapy, sir.
Which patient you would like to give?
As in case of COPD, sir.
When? Well, whether you are going to recommend for this patient?
Sir,
Because
so
you
for
see,
that,
just
to
since
give
last
supplement,
advice for this patient.
sir, so we'll look
Not at
based
all,
on
not at
the
all. It's not at all. It's
PO2.
not at all. This patient is not in respiratory failure. It doesn't
Yes, sir.
require.
Yes,
See,
sir.
actually, in the general physical examination, you are supposed to do nowadays. Everybody is doing, especially after the COVID. People are palpation pulses. Then I don't think they will palpate. Everybody will see that pulse oximeter. That is also should come under the general physical examination. No, your partial pressure of SpO2 has to mention there, isn't
Yes,
it?
sir. Yes, sir.
One of the important things. Anyway, you read about the long-term oxygen therapy. Long-term oxygen therapy.
Yes, sir.
So, is there any problem giving oxygen to the COPD patient? It's a pakka
Uh,
COPD patient.
problem, sir.
Suppose how much oxygen you have to give in how many liters?
Yes,
How
sir.
many?
So we
How
start
many
with so we start with 1 liter
okay, okay.
oxygen per minute flow,
Read
and
read
okay,
about
sir.
that.
Okay, sir.
Okay. Anyway, you want me to ask any? You want to ask anything?
No,
Any
sir. It was a
doubt?
wonderful session, sir.
Huh?
It was a wonderful session, sir. I have no questions from my end, sir.
Okay, very good, good, fantastic. Anyway, your presentation is very good here, and only the thing is, I always tell 3 times. One is careful, be about history, history, history. That's very, very important. Some patient, some they are not intentionally hide. They will don't take it as a consideration. It's very serious. So that's the thing. Anyway, Dr. Prakriti, congratulations. You have done a good job.
Thank you so much, sir.
To moderate.
Thank you, sir. Now I would be opening the audience for the audience are welcome to ask any questions or
Yes.
clarify any doubts.
If there are no questions, Aditi, please move forward to vote of thanks. Sir, wonderful moderation, sir. Excellent.
Thank you, sir. Thank you.
Excellent. Almost 1.5 hours. We don't know how it went. Very, a very knowledgeable session, sir. Thanks to Basuraj also for coordinating, head of the
Thank you, sir. On
department,
behalf of him, thank
and
you.
all your
He
department.
only provided this opportunity.
Yes, sir.
I
Yes,
must
sir. And
thank
all
him
your
also because
department
he
staff,
only provided this.
Gaurav, Aditi, for everyone. Thank you. Aditi, please proceed with vote of thanks.
Yes, sir. Thank you so much, sir. Now I would like to call upon Srinidhi to do the vote of thanks.
Thank you, ma'am. Good evening, everyone. Myself, Srinidhi S. It gives me an immense pleasure and privilege to deliver vote of thanks on behalf of Indian Medical Association, Medical Students Network, and Indian Medical Association, Karnataka State Branch. First and foremost, I extend our heartfelt gratitude to our esteemed presenter, Ms. Prakriti Kumar Aryu, for her clear and insightful presentation. A sincere thanks to our respected moderator, Dr. H.M. Virupaksha sir, for your
Thank you.
expert
Thank
guidance,
you.
observations, and seamless moderation of the session. I would also like to extend special thanks to our pillars of support, Dr. V.V. Chiniwala sir, President, IMA KSB, Dr. Suriraju V. sir, Honorable Secretary, IMA KSB, Dr. Narayan Murthy sir, Chairman, Academic and Medical Education Subcommittee, Thank you for your vision, encouragement, and support, sir. To everyone joined us today, thank you for your presence and support. Wishing you all a good night. Thank you. Jai IMA.
Thank you. Sir, Virupakshappa sir and Prakriti, you will be getting your e-certificate soon, sir. Thank you, sir.
Okay, sir.
Thank you.
Thank you.
Thank you.